at Elder Care Management. And she just does a fabulous job of networking for us out there, letting people know what kind of resources we have available, and developing programs like this for community members. So thank you to Maureen. I really like the title of this presentation, that word navigating, especially because I feel like it really lends itself to the experience of finding oneself in the emergency room and the hospital setting. You feel like you need a roadmap to prepare you for the obstacles and the challenges and the detours and everything that you find once you experience an emergency room visit or a hospital admission. So hopefully by the end of this presentation, you'll feel like you have seen it from the back side and the inside, and you can develop for yourself what a roadmap for you is going to look like when you experience that. I imagine that most of you probably had an emergency room visit either for yourself or for a loved one, and may or may not have had such a good experience. I think anybody who's had multiple ER visits has had at least one that has not been so favorable. So our goal as care managers is to always try to make an ER visit as tolerable as possible, as productive as possible. So all that said, this is just an overview of the topics we're going to touch upon. When is it time to go to the emergency room? That's a really good and important first question to talk about. What are some items that we think are helpful to bring along if you have the opportunity to be prepared for that kind of an adventure? And in light of today's events and the challenges in the world that we're currently facing, how is COVID-19 impacting the ER and the hospital experience? We'll talk about what you can expect upon arrival. Once you cross that threshold, what is the typical trajectory of an ER visit and or a hospital stay? We'll discuss treatment and diagnosis, how treatment is decided upon, how do you navigate and stay on board with everything that's coming with you information-wise, and how do you advocate and manage information so that you can get the best possible outcome for your loved one. We'll discuss also admission to the hospital and some details that are important to know for that. And then also discharge, because the impact of an emergency room visit or hospital stay doesn't end once you leave that setting. You head home, and there are things to be known and understood. So how do you know when it's time to go to the emergency room? Well, rule number one, we agree as care managers, is when in doubt, go get checked out. So if you really don't know and you don't have anybody nearby to either call or consult or give you feedback, go, because you don't want to land yourself in worse trouble because you delayed getting the help that you might need. We all see posters in doctors' offices and sometimes even in public settings that talk about signs of stroke or heart attack, chest pain, shortness of breath, a sudden change in blood pressure, things like that. Those just are not symptoms to tarry with and to delay getting care. So we always suggest that a 911 call is a safer bet than not under those circumstances. So just a sampling of symptoms. One of the things that we talk with all of our clients about, and for which we're very aware because we work primarily with an aging population, is making sure that any fall is checked out. You know, if you have a loved one who falls at home and there is involvement with the head or they can't get up, that's an ER visit. Even if you were to call the doctor's office and say, you know, my loved one just fell in the driveway and struck their head, there's no blood, but they're in all likelihood going to tell you to go get checked out at the emergency room. You know, I had an experience recently where two of my clients were in the emergency room at the same time. And one happened in the same hospital, no less. And one happened to be a fall that did occur in the driveway after a nice afternoon jaunt around the neighborhood. And he did not hit his head. He had some pretty serious abrasions on his arms and was bleeding quite a bit. He could not get up, and that was his telltale sign. He pressed, luckily enough, he had his emergency alert device, which rallied you know, emergency personnel who happened to be right around the corner at the fire station to his aid. And then I was called and was able to meet him in the emergency room. So, you know, he knew he needed help because he could not get up himself. My other client happened to have a urinary tract infection, which is another common ailment that we see in many older adults that can cause an onset of confusion or increased agitation in those with dementia. That change in mental status, something's not quite right. She happens to be a resident in an assisted living community. So the staff there realized something's going on. She needs to go get checked out. This was not something that could be a call made to the primary care's office and, you know, an appointment scheduled for 2 or 3 days from now. There needed to be some diagnostic tests run. Neither of them resulted in an admission. They were both treated, but both very appropriate emergency room visits. And the staff there got kind of a kick out of me ping-ponging back and forth between the hallway where my gentleman client was and the room where my other client was. So it was an interesting evening in the emergency room for a care manager. Another client of mine recently visited the emergency room. He also is in residential care in a smaller setting. He has advanced Alzheimer's, and he had a fall and struck his head and needed stitches. Very definitely an emergency room visit. Sometimes people wonder if they're on hospice, if they should go to the emergency room. And there are times when that's very appropriate, even though they won't be seeking, you know, restorative care per se. And a fall that results in bleeding and the need for stitches, it would be an example of that. So hospice doesn't necessarily preclude a visit to the emergency room. So again, falls, we want to make sure that even if there is no outward injury, that, you know, we don't have X-ray vision, we want to make sure if we have a client who can't self-report necessarily when the fall happened or how they're feeling as a result, we find them on the floor, we're a little suspect. We want to know that we've got complete information, and we'd rather find out there's nothing that occurred because of that fall than to find out later on there was an underlying, you know, pelvic fracture. I've seen that happen, gone undiscovered until a person was really suffering. So we just want to remember that we're, as care managers and family members, you know, most of us are not physicians. We don't diagnose, we don't treat. So, but we want to facilitate that when we're unsure. So that's when to go to the emergency 101. When we think about going to the emergency room, generally it's an emergency, it's a stressful time. It's helpful if you've done a little thinking in advance about what might be beneficial to have along with you. And as care managers, this is one of the areas where we focus on with our clients, and that is education and preparation. So from the moment that we initiate a relationship with a client, we're educating them about how to be prepared, not just for an ER visit, but for the other challenges that the aging process is going to bring them. But specific to an ER visit, we really feel like the most important thing you can bring is an advocate, a family member, a caregiver, someone who knows you well, who has a sense of your health history, because you may or may not be able to speak for yourself. And so they can reach out to people who can speak for you, or who can make a decision for you, or who may have the information. But by all means, bringing someone with you. And when you bring someone with you, that means you don't drive yourself. I've had clients who did that very thing, and in one sense, maybe they didn't belong at the emergency room if they were able to drive themselves. And on the other hand, by taking themselves there, they really endangered themselves further and other people as well. So we always discourage self-transportation, and that just goes hand in hand with bringing that advocate with you. So, and that advocate can follow an ambulance, can take a person if it's appropriate, can meet you there, however that needs to happen. But having that extra person there is the top of our list. We think it's important to have some pertinent personal information always at hand in case you do need to go to the emergency room. And it can be, that pertinent information can be utilized in other emergencies as well. We've seen plenty of emergencies in the state of California in the last 5 years to substantiate that need. So, but for the purpose of an emergency room visit, perfectly appropriate. Elder Care Management has something called My Personal Toolkit. So this is a packet that we've assembled that you can use as a guide. You can use it in its entirety or just parts of it. And I know Maureen is going to make that accessible at the end of the presentation if you're interested in it. But essentially what it is just a collection of your pertinent personal information. Who are your doctors? What hospital do you get your care at? Maybe you've got a couple of neighbors listed on there, somebody to feed the dog while you're at the emergency room. Maybe your home alarm company is on there. You've got your medications listed in there, your insurance information, and it can go as deep and as wide as you want to develop it. But having some essential information in there and at your fingertips that you or your helper, your advocate can grab, can make all the difference in the world once you land in the emergency room. We all like to believe that we're going to remember all that essential information, or maybe it's on our phone that got left behind, or the battery dies, or we didn't take the charger. So nothing replaces paper, really. It can just be a lot easier for your helper to navigate than information on your phone. Nothing wrong with having it, on an electronic device, but again, good old-fashioned paper, nothing can beat it. So that advocate is going to be able to scribe for you as well. So having, a notepad and some paper there with your pertinent personal information or your toolkit, just kind of ready to go in a Ziploc bag. Simple tools, but can really come in handy. So as they're acting as an extra set of eyes and ears for you, not only sharing some information that may be pertinent, they're also able to collect it for you, because as you may have experienced, when under duress, it's not always easy to absorb information and retain information which you may need later. A current list of your medications and chronic medical conditions is especially helpful. It's not necessarily important to grab your medications physically unless you have certain specific medical conditions, and I'll touch on those in a moment. But a list of current medications is very, very important. Not only is it going to tell paramedics who may be transporting you what medications you're on that may be either causing a condition or that you will need, but it's going to give physicians at the hospital who are going to be trying to diagnose or treat a lot of information about you. We really encourage our clients to have their advanced healthcare directive posted somewhere visible along with that current medication list. I'm going to talk in a few minutes about a type of advanced care directive called a POLST, P-O-L-S-T. Don't worry, I promise I'm going to explain it to you. It's a simple way to communicate your advanced healthcare directive, your wishes, and it's easy to display with that current medication list. So those are two such essential things to have when you are seeking emergency medical care. And of course, having that medication list, any known medication allergies that you have is very important as well. There have been times I have forgotten the name of a medication for a family member, a known allergy, because I was under stress. I just could not capture it, could not recall it. And it's just important to write that information down and have it accessible. Insurance information and identification. Identification first, insurance information second, both important. But again, copies of those can go in that pertinent personal information, that toolkit that you assemble for yourself, okay? Because we are in an era of COVID, a copy of your vaccination card, if you have one, okay, for yourself and your advocate, the person who's coming along with you. It will help streamline things for you if you've got it. Many healthcare systems are documenting that now. You can keep a copy of that on your phone. I've used my own that way a number of times now. It's accepted. They just like to see proof of it if you've got it, okay? So some of the non-essentials but really nice things to have, a warm sweatshirt, maybe a blanket. Usually you can squeeze one out of hospital personnel, but emergency rooms are notoriously chilly. If you bring your own, you know where it came from and it's clean, and usually that's going to be for your advocate, not necessarily for you, but good to have. A water bottle for your advocate, not for yourself. Snacks, same. Reading material for your advocate, because you're as the patient liable to be busy doing other things, not maybe really feeling like reading, but you never know. And a phone charger, because as we all know, phones don't always arrive fully charged when we need them. So you're likely to be needing to contact people, or your advocate might need to. So just a few things there, and not unwise to maybe have an extra phone battery if you're anticipating that a hospital visit or an ER visit is on your radar in your future. You know, just some little handy tools like that can come in, can be helpful. One of the things that isn't on here that I've found handy too is an iPad. And I'll touch on that a little bit more later, but if you're one who is going to perhaps be frequenting the ER or the hospital, and especially if you have a loved one with cognitive issues, dementia, an iPad can come in handy. It's a good diversion tool. That's something that you can decide if that might be helpful for you. I want to talk a little bit more about the POLST because I mentioned it in the last slide. And some of you may be familiar with it, some of you may not. POLST stands for Physician Orders for Life-Sustaining Treatment. This is a document that is recognized across the state of California. In fact, most states now in the country have something very similar. The acronym and the title might just be a little different, but the purpose and the structure is the same. As you can see, it's divided into sections, starting with cardiopulmonary resuscitation. Does the patient desire to be resuscitated if their heart is stopped or not? And then it just moves through levels of medical intervention that a person is likely to encounter in an urgent care emergency hospital setting. So it addresses what level of treatment you want, and then also touches on artificial nutrition. What makes this form different than a multi-page advanced healthcare document is that this one is signed by the patient and their physician. It makes it a medically enforceable document. It follows the patient from home, where it's posted in a visible place for emergency responders to see, and it follows them from home to the hospital. It speaks for them there. It can follow them from the hospital to a rehabilitation setting after a hospital stay, and it can follow them home again. It can also follow them to an extended care setting like assisted living or memory care. So it's a portable document, and that's one of the things that we like about it. And it's well recognized now across healthcare settings. It speaks clearly to what patients want, and it speaks clearly, it's concise, and it prevents a person from having to repeat and complete over and over an advanced directive that might be presented to them by individual facilities. So it can help streamline care and guarantee that you receive the level of care that you want. So we're real proponents of the POLST in our practice. And we think it's particularly important for anyone who's living alone, because if you are to have a medical event and were to call 911, and by the time they arrived, you were not able to speak for yourself, this form can speak for you. I also like to encourage my clients who are couples living at home alone and one may be cognitively impaired. I think it's important for them both to have one, because the cognitively impaired person, the person living with dementia, likely cannot speak for themselves, and they also cannot speak for their cognitively whole or intact partner. So we want that partner to have good representation of their healthcare wishes as well. So caregivers need to think of themselves in that context as well. So we just really like the POLST. It works in tandem with that multi-page advanced healthcare document that more and more people have. It puts into action the philosophies of that document and really makes care easier and more accessible for patients. So if you're interested in having a POLST, you can speak to your physician. Most physicians are familiar with them now, and that can be completed as part of an appointment with your doctor. All right, so how has COVID-19 complicated emergency room and hospital stays? Well, it's a fluid situation, that's for sure. It's almost like listening to the news daily. You know, it seems to change daily. Last year, we found that we weren't permitted into the emergency room and often into the hospital with our clients. If you had a loved one who had one of those encounters, you may have found the same. It's all the more reason to have that toolkit of information and to be prepared for an emergency room visit. Just being prepared for the challenge of what the rule today may be regarding admissions because of COVID-19. So the first thing, one of the first things is don't be afraid to go to the emergency room because of COVID. If you need to be seen, don't let that prevent you from going. I've been into the emergency room now probably 10 times since COVID became an issue. And medical personnel, they're conscientious. We've found that the duration of the ER stay is a little bit faster, probably as they're trying to get people in and through the process. So not always, but in general, there seems to be a little bit more emphasis on being efficient with the time. So again, the importance of having your vaccination card so they know what your status is. So we as care managers always want to be with our clients when they're in the emergency room, because there's usually a reason they have a care manager, and a large part of it is because they need our advocacy for some reason. So what place would they need that more than in an emergency medical setting, right? But we've been able to leverage that a little bit by, explaining our role efficiently and succinctly, and helping medical staff there at the ER recognize that we're an ally, that we have information that the patient may not be able to share because of their medical or cognitive status, that we are a liaison for family and decision makers. And that we know about this person. We can help streamline and enable cooperation and so forth so that they can do their job more efficiently. So, an advocate who you take along with you could present themselves as the same as an asset and an ally to the process. But there were times, in the last year and a half where it didn't matter how well we pled our case. We were not allowed in, but we didn't go far. And so if that happens to you, we encourage you to do the same. Plan to stay in proximity, because you never know when you might be needed. If you cannot accompany your loved one, we strongly encourage you to get as much contact information regarding the space where they are and who they're being treated by. So a phone number, just politely ask, what's the best number for me to call for an update, please? What's the name of the physician who will be treating my loved one? And could you give me the nurse's name too? And if you do talk to someone on the phone, make sure you get their name. Keep a little log for yourself. Don't be afraid to be a pest, just be a polite pest. And give them your contact information. Let them know how they can reach you and where you will be, who you are, why you're important. And tell each person who you come across and who you talk to. Provide that medication list for them. Give them that insurance information, okay? And again, this just underscores the importance of having a plan, having that information at your fingertips ahead of time. Because if you can't get in to do the one-on-one advocacy for your loved one, you've got the information there that you can put through the appropriate channels so that they can get the care that they need. Okay, what to expect? I have a son in the Marine Corps, and so one of our favorite sayings is on this slide: hurry up and wait. And again, COVID has, somewhat lubricated the emergency room process, but when you're in pain or you don't feel good enough so that, you're in the emergency room, waiting is really hard, but it is a part of the emergency room experience. So it's just something to be prepared for. And time has a really strange way of moving when you're sitting in the emergency room anyway. And I just like when I'm with a client, I try not to keep them talking the whole time, but just let them know that I'm there and present, help them process a little bit of what is happening, try to answer questions for them when they feel like they need some information. So, those things help to pass the time and so forth. But once you get your foot in the door, there will be an initial triage process where a nurse will determine, what is it that brought you here, right? There may be some initial vitals that will be taken, and depending on the need and the level of, emergency surrounding you, you could wait in the outer area with a lot of other people who are waiting for care, or you may be taken right back to a room and you may wait there. So again, you can understand why it's so vital and important to have an advocate, another person with you in that case, because you could be on your own for a while, and it's kind of nice to have somebody who can peek their head out from behind the curtain and wave at a nurse, hey, are we going to see the doctor soon? So gosh, it really speaks to the importance of having that advocate when you're going to have to wait and you're going to be moving through different parts of the emergency room. So assessment, again, is going to be highly individualized depending on, what brought you to the emergency room. You're liable to have some tests. Is it going to be blood work? Is it going to be x-rays, CT scans, something higher level? Completely depends on what brought you to the emergency room. Your advocate can get out that notepad and that pen and start making notes. When was blood drawn? When did you go for an x-ray? What other tests were done? Draw another column as the results start to come in. Collecting that information. Don't try to do it all on your own. It's too hard to do when you're the patient. So, utilize that advocate, that person who you've taken along. And again, tests can take a long time to get the results for, especially if an emergency room is really busy. And these days, I haven't seen a one that isn't. So the hurry up and wait is the bottom line there. Okay, for diagnosis and treatment, here you are. You've had the tests. The physician has been in and talked to you maybe a couple of times trying to decide, what they're going to do. Ask questions. There's no such thing as a dumb question, right? So I ask them all the time. I'm not ashamed. What does that mean? Okay, well, how long will that take? Well, what will that tell us? How does that play into the last thing that was done? And if you have knowledge of the loved one who you're there with, or your advocate knows, recent tests you've had done, that's information to be shared that can be fed into that process, right? So any test results that you're given, ask for a copy of, especially if you're in an emergency room that's part of a hospital and you're not a part of that particular healthcare system. It's outside of your usual healthcare system. It may not be as easily accessed later. So ask for a copy of it. It means they're going to have to go to a printer or make a copy, but that's okay. You can ask. You're the patient, you're the customer. So ask for what you want and what you need, okay? It could be important later on when you see other physicians. So following up with your primary care provider, usually it's within a week, sometimes it's less after an emergency room visit, is very important. You're going to want to discuss, what landed you in the emergency room to begin with, right? Are there follow-up tests that need to be done or follow-up care? Again, just depends on what landed you in the emergency room to begin with, but don't neglect that follow-up with your primary care. You know, the goal would be to prevent, you know, another emergency room visit or hospitalization. So doing that primary care and working on from a preventive perspective is a healthy thing to do. Okay, so and it's also not a bad idea to take your advocate along with you to your follow-up. Okay, they've been a part of that journey and can continue to be an extra set of ears and eyes and scribe for you at that follow-up appointment. Okay, sometimes emergency room visits aren't just visits. They end up being a precursor to a hospital stay. There's a few things that we think are important for you to know about staying in the hospital, okay? The first is that hospitals now are very acute in their focus. They're going to be zeroed in on what brought you there, okay? Many people have other health concerns and issues, but they're going to be primarily focused on treating the issue that brought you to them for this particular stay. Doesn't mean they're going to ignore your other care, but you know, you might have had a tennis elbow or a bum knee or something that has also been bothering you for a long time, but it was really a collapsed lung or a broken arm or something else that brought you to this hospital stay. They're going to focus on that, and they're going to maybe treat your pain or continue whatever treatment you had for your other maladies, but they're going to focus on the thing that brought you to the hospital. So you're going to want to advocate again for yourself, and your advocate, your loved one who came with you, is going to want to stay on top of things, make sure that they know what your other conditions are. So again, goes back to the importance of having supplied that early information. Okay. Hospitals don't like to have what's called readmissions. So you want to be cautious in understanding some of the lingo of admissions. One of the ways that they avoid a readmission, and that is somebody who's been in the hospital within the last 30 days, they get dinged for that, especially under Medicare. So there's something called observation status. Always clarify when you're admitted to the hospital that it is a formal admission and not an observation status. And if it is, you want to ask to speak to someone from admissions and your medical team and find out what is preventing you from having a formal admission to the hospital. What diagnostic routine is being followed? What's the definition? Poke, ask questions, because you have rights and you don't want to find out after the fact. The reason being that without a formal admission, you could end up with a large bill that you're responsible for because insurance didn't cover it. So pay attention to what you sign. Don't let a loved one sign something without you present if you've got any concerns about their ability to understand what they're signing. So, and likewise, don't sign something for someone that you're not sure what it is. Ask the person who's presenting you with the paperwork. Can you please explain this to me? I'm not quite sure what it is I'm signing. I've done that many times. Ask them, can you please tell me what this means? We can get easily into the habit of just signing away because we want to get things going. And certainly we don't want to hold things up, but we don't want to proceed without knowing where things are headed. One of the things about making the transition from hospital or from an ER visit to the hospital admission is that your medical team is going to change again. So in the emergency room, you have emergency room personnel. You have the nurses and the emergency room doctors. That's their domain, okay? They've done their tests and they've done their diagnoses what they think is wrong, and they think you've got to be admitted now. They're transferring you to the care of a new team in the hospital. You're going to go to whatever floor is appropriate, and you're going to be under the care and supervision of the nurses on that floor and the hospitalists, the doctors on that floor. Okay. So guess what? All that communication you did in the emergency room, that's right, you're going to repeat it all. And it's okay if they think that they know, oh yeah, we got the med list. Oh, just make sure. And did they get the pulse and the advanced healthcare directive? Just make sure. And do they know who you are? Just the advocate, just make sure. Okay. It always bears repeating. And you may find that you have to repeat it every few days as the shifts change. So nursing shifts are about 12 hours. Hospitalists might be on for 3 to 5 days. Where are they in the cycle? So are you're coming in, being admitted to the hospital, it's Saturday afternoon. You've been in the ER since Friday night. Now you're being admitted, it's Saturday afternoon. Did the hospitalist just come on this morning, Saturday morning? Or are they just going off tomorrow? See, so you're going to have a changeover. And in every changeover, it's an opportunity, an obligation, an opportunity to, again, communicate what you know and to make sure everybody's tracking, right? You just can't share enough information. If you're the advocate, make sure your name and phone number is on the board in your loved one's room, and you've written who you are next to it. So are you daughter and power of attorney? Write that, and your phone number, your name, your role, your phone number. Okay. Discharge is something that you're going to start hearing the minute you or your loved one move up onto that floor of the hospital and are admitted. They're going to start talking to you about discharge. So, and we'll talk about that a little bit more later. But you're going to say, well, what do you mean discharge? Well, the minute you cross that threshold, they're already planning for what they're going to have to do. So again, another reason to be sharing information. Okay, so let's see where we're going next. The challenges of navigating the clinical setting for a loved one who has dementia. All right. One of the things as care managers that we are so passionate about is understanding that our clients with dementia, they're not able to adapt to the clinical setting. We want to get the clinical setting to adapt to them and their needs. And the best way that we can help facilitate that is to help medical staff understand who they are, because they're not going to be good historians for themselves. They're not going to remember why they're in the hospital. They're not going to remember their health history. They're not going to remember most of the things that medical staff are going to need to know about them. Will they know in the moment if they're in pain? Yes, most likely, right? Or staff will be able to recognize that they are, but the other important information they won't. We want to help staff understand what their needs are that are going to impact the quality of their care, right? So were they feeding themselves at home before whatever event brought them here? Were they using a walker? Did they need help using the toilet? Did they need help dressing? Do they wear hearing aids? Do they wear glasses? Do they have, all of their own teeth? Do they have a special diet? Are there cultural considerations? So all of those things that might be communicated by somebody who's cognitively intact, we have to think about doing for our clients and or our loved ones when they have dementia and are in that clinical setting. So, our team, we've developed a little tool about our clients to help prompt that. And it talks about, what language, are there cultural considerations, are a few important facts about our client. what are their baseline activities of daily living, meaning what kind of help do they need with daily routines? And then who are the important people, the important contact people? So that might be very similar to some of that pertinent information you would put in your toolkit about yourself, right? But getting it to hospital staff and just politely interacting with nurses as they come in and out, and other staff, physical therapists, letting them know who is this person and how might they best communicate with them. Maybe there are certain questions that they could ask, or things they could mention when they're working with them or trying to get them to cooperate, that might facilitate and make that delivery of care smoother. Okay. Asking for help. So harkening back to, trying to get your foot in the door in the emergency room under COVID, and, presenting yourself as an ally and an asset to the system. The same goes with a hospital admission for someone with dementia, helping the team there understand that you're there to help. You also sometimes may need to ask for help, you the advocate, okay, you the caregiver, making arrangements for an outside agency to sit overnight with your loved one so you can go home and get some sleep, okay? Hospitals are very open to services like this for patients who have dementia. So we encourage our client families to think about that when the need presents it, that it's okay to ask for help. And so, navigating in the hospital isn't easy for anyone, but especially for those who are living with dementia, we want to do all that we can to make that process friendlier. All right, so discharge home from the emergency room. So we're back in the emergency room, and we're being told, okay, you can go home. We stitched up your arm here, your abrasion, or we've given you antibiotics for the UTI, or we sewed up the head. So you're ready to go. You can get out of here. So what do you need to do to make sure that emergency room visit has been as productive as possible, even though you're no doubt ready to get out of there yourself? Hold on, make sure you got what you need. Okay, so did you get those test results, right? They did blood work, they did x-rays, they did an MRI, they did a CT scan, whatever it was they did. Did you get all the results, and did you get those copies for yourself? Okay, a little printed report, really important. Okay, do you understand what the follow-up care is that you're going to need? Okay, is it something more than a primary care visit, right? Make sure you understand, how are you supposed to clean that wound on the head? Okay, between now and the 3 to 5 days when you see your doctor, can it get wet? Okay, ask questions. Don't. There's no such thing as a dumb question. All right. Okay. If you or your loved one live in a residential care setting, meaning you live in assisted living or memory care, those are settings which are regulated. Okay. If that community has been tasked with the responsibility of giving you or your loved one your medication on a daily basis, they're going to need a signed order for any new medications. So let's say you went to the emergency room for a urinary tract infection and you're being discharged with a new antibiotic and you're going back to assisted living. Advocate and patient, make sure you get a signed order by the physician to give to your assisted living community, to your wellness office, the nurse, whoever is in charge there. They can't give it to you otherwise, okay? As a brand new care manager, that was one of my first mistakes, so I'll never forget it. I landed back at the assisted living community with my client. It was 12:30 in the morning, and I said, "Oh, here's the discharge orders and the the prescription will be here in the morning. And I got the call the next day, well, you didn't get a signed order from the physician. So I had some work to do, but fast, to get that taken care of. So always make sure you get a signed order. And if you're not sure if you need one, get one. Okay. And that goes for over-the-counter medications as well, if you or your loved one are in an assisted living setting. Okay. The emergency room does not generally fill prescriptions. So find out, does the prescription, is it going to be sent to the pharmacy? Are you going with a hard copy? How are you going to navigate that? So don't leave before you know and understand that. Okay. You want to get home and then say, oh, were we supposed to get that somewhere else, or did we need a copy, or was that sent in? Was it an electronic transmission? How was that going to happen? Okay. And then if there is a new prescription, make sure you get it added to your medication list. Okay. Especially you may end up having a repeat, let's hope not, emergency room visit, right? Jot it down on your list. Okay. Even if it's a temporary prescription, maybe it's a 7-day antibiotic, write it down, put the date started for yourself, for others, for your advocate. They've got to scoop up that information again, within the next few days. And unfortunately, that does happen. So it's helpful to know what those intermediate changes and adjustments have been. Sometimes you might need help at home after an emergency room visit. So that could be in the form of, some home health. Probably not if it was just an ER visit, but possibly that would be generated by a doctor's order. Home health is a temporary thing, might be some physical therapy or occupational therapy. It's going to be limited in duration, might be a couple of times a week. It's not heavy duty medical care. It might be some minor nursing care, like for a wound or something like that, but it won't be daily. And it won't be long-term. It's very short-term. Okay, so durable medical equipment, things like that might be needed. Do you need a wheelchair? Do you need crutches? Do you need a walker? So those are all questions to get answered and find out, where is that going to be procured, right? Okay. All right. So discharge home from the hospital. Remember I talked about how the minute you're admitted to the hospital, the discharge planner shows up? It's true. It's always a little confusing, but the reason is because they're going to start working on that discharge for you from day one. They're going to be a part of your medical team. And so you're going to want to communicate with them from the get-go, what things are like at home. Okay, so you're going to start to understand what the length of your stay is going to be, asking questions, what's going to impact the length of your stay. Is there a surgery? Is there follow-up medical treatment that's going to happen in the hospital? Is there IV treatment you're going to need for 3 to 5 days? You're going to be there for that long. Okay, try to gauge and know that it could change. But, get an idea and be communicating with the discharge planner what things are like at home, right? Do you live in 2-story? Do you live alone? Do you live with somebody who can't provide any care? What are other limitations or advantages in your setting? Maybe you have a setup at home that's completely equipped and you have 24-hour care. You don't need to think about care beyond between the hospital and home. Okay, so that all those things are important to factor into and share with discharge. You want to begin coordinating with the discharge planner as discharge approaches for needs beyond the hospitalization. So again, durable medical equipment. What's going to be needed at home? Are you going to need a bedside commode? Are you going to need a walker? Are you going to need a hospital bed? Those are all things that the discharge planner will work on and help to put in place if those are going to be needs at home after the point of discharge. And the sooner they can work on those things, the better. You don't want to be delaying a discharge because you don't have what you need at home, or likewise arriving at home and not have what you need. Some insurance will cover more durable medical equipment than others. If you're not sure, ask. My coworker always asks for everything. She'd rather be told no and not get it than not ask and not have what her client needs. And if you don't quite need it yet, but you might, and it's offered, she suggests that you accept and you put it away for the time that you might, especially if insurance will cover it for now. There are durable medical equipment stores locally for items which insurance does not cover, and there are some helpful things out there that insurance does not cover. So it's definitely not comprehensive what insurance will cover. Sometimes a hospital stay is followed by the need for a rehabilitative stay in a skilled setting, sometimes called a skilled nursing home or just rehabilitation. For Medicare, unless you are in a Medicare Advantage plan like Kaiser, you will be required to have 3 consecutive nights in the hospital before you would qualify for a setting in a stay in a skilled setting for rehabilitation. So that's something to kind of plug into your knowledge bank there. You can't think about a stay elsewhere if you haven't completed that 3-night stay. Not everybody needs a skilled stay after a hospital stay. They may be able to just graduate right to home with something called home health. And this is something that is covered by Medicare and most insurance as well, okay? But instead of having the round the clock and daily assistance that would be available in a skilled setting, you're going to have visits from a nurse, probably a couple of times a week, potentially physical therapy and occupational therapy, again, depending on your needs, speech therapy. But home health is very short term, generally, 3 weeks usually. As care managers, we always like to push the envelope and encourage others to do the same. Always ask for an extension. Could we get just a few more visits, right? Why not get as much of that rehabilitative assistance and effort as you can, okay? So you also may need help at home with things like meal preparation, dressing, bathing, all right? None of that's going to be covered by insurance unless you have a long-term care policy that's already kicked in or will down the road because you have substantiated that there's need. So that will be private pay and it's expensive, but if that's what you're going to need to transition successfully from hospital to home, then we encourage you to lay that groundwork, make those plans, and accept that care and that extra assistance. Do what you can to make arrangements for it so that you set yourself up for success and you don't repeat the cycle of back at the ER, hospital, and so forth, because that's expensive as well. It's expensive financially and to your quality of life. So really consider carefully, what kind of supplemental care you put in place for yourself or your loved one. I always like to say, start with more, because you can always reduce quickly if you find that you've planned for too much care. So, if you're not sure, start with 3 hours of help during the day, and then maybe an 8-hour shift overnight for your loved one, right? So you can get some sleep. Or if you're home alone, and you're able to get along okay at night, get 4 or 5 hours of help or more if it's needed during the day to help get you back on your feet. You can always trim it back, but it can be harder to bump it up once you've started. So set yourself up for success in that way. Oh, the big question, who's going to pay for all of this, right? Well, Generally, your insurance is going to include co-pays, right, for an ER visit and a hospital stay. Um, you know, I explained to you the criteria for a rehabilitation stay. You don't want to set yourself up for having to pay for that by not having that 3-night minimum or having that expectation that that's what you're going to get. If you feel that you're being discharged for prematurely, or that you haven't received the care that you need in order to return home safely, or things aren't ready for you at home, you can appeal a discharge, and you want to speak with the discharge planner about that and make your case. Medicare does have guidelines for appealing a discharge, and the hospital is obligated to walk you through that process. You can lose an appeal for a discharge. It has happened, and be liable for the extra days that you were in the hospital. But if you feel that it isn't safe for you to go home, then we encourage you to go through that appeal process and ask for the assistance that you need. So Plan B, what does that mean? Oh my goodness. Well, you know, sometimes the best laid plans just don't work out the way that we think. And we end up at the end of an emergency room visit, or at the end of a hospital stay, or partway through a hospital stay, and realize, yeah, we can't go home. We can't get up the stairs to the bedroom and the bathroom. Or, yeah, our loved ones' confusion has advanced to the point where they can't safely return home by themselves. All right. So we like to encourage families to start conversations way in advance of emergency room visits and hospital stays. What are we going to do down the road when? Who's available to step in and take care of mom or dad or Aunt Sue or Uncle Joe when they can't be on their own anymore? Have those conversations as a family or with your friends, whoever you've incorporated into your decision making world, and talk about it. We as care managers have resources to share in that way, helping families discover and investigate what are different care communities. What are the different levels of care? What does that look like? Educate yourself now with, even conference calls and educational opportunities like this. We've had many this year, and there are other organizations in the area who do the same, talking about, how to be prepared for the changes ahead. Home always sounds like an ideal place, but there are, we can tell you as care managers, been many times when we arrive at a point with our clients where home's no longer the best place. So talking about and having that plan B is important, and you'll be glad later on that you had the discussion. And it may not be that things work out entirely according to plan B, but you'll be able to mine that plan for support and for information and for assistance down the road. So I think I have told you just about everything I can mine today regarding emergency room visits and hospital stays. I again, going back to my early days as a care manager, I remember being very timid and kind of shy about, wading into and navigating that whole scene. And it's like anything else, now I've done it many times. I'm much more confident, but I still remember that feeling. That I think it's important to just believe that you're going into that setting for a reason, and with you and your advocate, and the tools that you're going to prepare in advance, you're going to be better equipped to navigate the obstacles that may or may not be there, but you'll be prepared for them if they are. And I think you'll have a more successful stay and journey and experience, and hopefully be healthier on the other side. So Thank you so much for joining me today. And I think we're going to have some questions now, hopefully, if there are some.
Thank you so much, Felicia. There's so much information in that presentation, and you did a great job giving some practical examples as well. So thank you so much for sharing all of your knowledge. With that, we are going to stop the recording, and we are going to answer a few quick questions.